Okay, we are ready. Good morning, everyone.
Good morning, everyone, to the Health Connector Board of Meeting, the Board of Directors meeting for September. And so I'd like to call the meeting to order. And Kathy, will you take the roll call?
I will be happy to. Good morning again, everyone. Commissioner Caljo,
Good morning, I'm here.
Michael,
Good morning, I'm here.
good morning, Bella,
Yes, here.
Dana. Okay, did not see that. Rebecca,
Good morning.
good
Here.
morning. Robin,
Here.
Dimitri,
Good morning, Kathy. I'm here.
good. Secretary,
Present.
Nancy,
Good morning, Kathy. I'm here.
good morning, and Matt.
Yes, I'm here.
Okay, thank you, everyone.
I'm here now too, I think.
Okay, hi,
I
Dana,
joined
thank
as
you.
you were saying my name and I couldn't unmute fast enough.
Thank you.
You may have missed me too. I'm here. This is Eric.
Oh, I'm sorry, Eric.
It's all right. I'll just be the fly on the wall.
Okay, we're good.
Equally on the wall, it looks like, Eric.
Yeah, I got literally the wall right there.
Very good. The first item on the agenda is approval of the minutes from June 12th, 2025. I'll entertain a motion to approve the minutes.
So moved.
Moved.
Second,
Thank you. And we have to have a roll call again by Kathy.
Okay, Secretary Caljo,
aye.
Michael,
Aye.
Bella,
Yes.
Eric,
Yes.
Dana,
Yes.
Rebecca,
Yes.
Robin,
Yes.
Dimitri. And Dimitri? I'll come back. Secretary.
Abstain since I wasn't there.
Okay, Matt,
Yes.
Nancy,
Yes.
Dimitri.
Yes.
Okay, thank you, everyone.
Thank you. The motion carries. Next item on the agenda is the Executive Director's Report, and I'll turn it over to Audrey.
Great. Thank you, Secretary. Good morning, everyone, and welcome to today's very important meeting, as we'll spend our time today discussing the upcoming open enrollment period and impacts to our members and applicants from federal policy changes and premium changes. But first, I would like to warmly welcome our new board chair, Secretary Kiami Mahania. We have had the pleasure of working with Secretary Mahania over the last several years in his role as Undersecretary, including through his leadership as co-chair of the Advancing Health Equity in Massachusetts initiative and on other priority healthcare issues facing the Commonwealth. As you'll hear today, we're at an extraordinary moment as we face headwinds created by federal changes, unrelenting increases in premiums, and other challenges facing the public we serve. But we are looking forward to working with the Secretary as we tackle these issues together. We feel so fortunate for his leadership and service. Before turning to those broader headwinds, particularly those caused by federal policy, I want to acknowledge and thank my team for their grit and determination in their work to continue building best-in-class customer service functions that deliver the excellence our members and our taxpayers rightly expect. We are working through new vendors on the delivery of core business functions and continue to experience progress and paradigm shifts in our work on both the call center and our enrollment and premium billing fronts. Our gradual transition to a new call center vendor, AHS, remains a steady, smooth process supported by our outgoing vendor, Accenture. AHS is now fully taking a wide range of call types and functions and is preparing to handle increased open enrollment volume as members seek help from us. AHS has been a great partner. At the same time, we are hard at work with our new enrollment and premium billing vendor, Maximus, working towards a cutover for next July 1st. There is an extensive amount of work going on daily to bring Maximus on board. So far, we have been deeply impressed with Maximus's preparedness and collaborative partnership with the Health Connector as we work on this complex, high stakes, and eventually high return undertaking that we're pursuing to improve services for our members. As you will hear in the policy updates and open enrollment readiness agenda items, since our last board meeting in June, it is the case that the federal government has, with the passage of the so-called One Big Beautiful Bill Act, visited upon us and the people we serve a set of stark setbacks that will result in losses of health coverage for tens of thousands of residents and impose cost increases on people who depend on the Health Connector. As this board knows, we, along with other marketplaces across the country and other healthcare partners, mounted our best effort to try to stop these changes as they were being debated and considered by Congress, so that we wouldn't see Massachusetts or other states lose ground on the tremendous progress we've made expanding coverage over the last 2 decades. We will continue to use our voice in every way we can to advocate for a reversal of these harmful policies. Today, you'll hear that of all the healthcare funding cuts that will arrive on our shores here in Massachusetts over the next few years between the Health Connector and Mass Health, our Connector Care Plan Type 1 population, comprised of 36,000 lawfully present individuals under the poverty level, will be the first to feel the pain, as this population will lose access to federal subsidies that allow them to be in Connector Care and keep their coverage affordable and attainable. Despite rhetoric we hear from the White House and congressional leadership, Affordable Care Act subsidies have never gone to undocumented immigrants. Every last one of these individuals losing coverage is here lawfully. People who played by the rules and came to our country and our great Commonwealth in exactly the way we tell them to. People who contribute to their families and communities, our economy, and our nation. As we think about this population, I know that all of us understand that these are more than statistics. There are neighbors leading full and complex lives all around us, whose lives are made safer through access to health care. In that spirit, I would like to share a quote from an individual in the Plan Type 1 population. This was shared with us in Spanish, so this is translated. Quote, "I have always believed that prevention is more important than correction. So having Health Connector coverage and being able to count on a primary care physician who manages my medical history as well as my family's gives me a feeling of security and peace of mind. I can prevent illnesses and challenging health conditions. I'm so grateful for every service you've provided me, always willing to fulfill your life's mission to the best of your ability, bringing to each of us, your patients, the certainty that we are in the best hands." One of the great reasons I can say thank you with all my heart today is being able to hear with my right ear, given that I hadn't been able to hear anything for 25 years. And although my left ear works, I can say my life has changed enormously since my health insurance gave me the opportunity to regain sense in both ears, unquote. At the Health Connector, we will do everything humanly possible to help support this population as these federal changes get rolled out and their eligibility for subsidized coverage changes for January 1st. And we look forward to earnest and, I'm certain, difficult discussions with our stakeholder partners and other state leaders in the coming weeks and months as we collectively seek to figure out how here in Massachusetts we can best support these individuals that the federal government is walking away from, and together take the first steps to navigate the $3.5 billion in federal funding cuts to our health coverage programs over the coming years. Another federal policy issue we continue to work diligently on relates to whether Congress will take action to extend enhanced premium tax credits, which will otherwise expire at the end of the calendar year. Without an extension by the end of the year, more than 26,000 of our members will lose their subsidy, including Connector Care Plan Type 3D coverage, the top half of the Connector Care expansion pilot, and find their health insurance next year significantly more expensive. Several of us have been working hard with other state-based marketplaces to urge Congress to take action and maintain what is more than $400 million annually in enhanced premium tax credits for our members here in Massachusetts. We are urging a solution by September 30th to reduce confusion and anxiety for members who will see starkly higher premiums for 2026 without the tax credits extended. We have already started outreach to all of our members who will be affected by federal actions, and in the case of enhanced premium tax credits, potential inaction, with regular communications scheduled before and during open enrollment. These communications will be specific to a member's situation, consistently urging members to update their accounts, shop for coverage, and consider options that will make coverage more affordable. You will hear more from the team today on these changes and how our management of them is flowing through our open enrollment preparations, our approach to seal of approval, and more. This upcoming open enrollment will prove to be our most challenging and complex in a decade. But as you'll hear today, we are using every tool and option available to us to support our members and deliver the best coverage possible to people who need health insurance. I am deeply grateful to our team who are working around the clock to continue to deliver our mission and reach for the next rung, despite the obstacles and challenges that have mounted, and even charging ahead, finding ways that we can keep improving things for our public in all the places that we have latitude to do so. Thank you to each member of my team for their public service, equally dedicated in times of headwinds or times of tailwinds. As we march forward in these unprecedented and turbulent times, we appreciate the support and guidance of you, our board, more than ever. With that, I will hand back to Secretary Mahania.
Thank you. Before I move on, any questions or comments for the director?
Yes, I had a quick question, Audrey. With regard to the type 1 members, do we have an estimate as to how many people may lose coverage as a result of the changes?
We
Proposed
would
changes, I should say.
We would be very surprised if anybody in the 36,000 population could afford coverage without the subsidies that they'll be losing. So we would expect the vast majority of these individuals to move to the health safety net.
Thank you.
Thank you.
Thank you, Dimitri. Any further questions? Please go ahead, Eric.
Thank you. Just want to thank Audrey and the team for doing all the work they've been doing this year to maneuver this and try to impact as best they can. People know I'm a relatively conservative fiscal person, but makes me very sad to see the legally present, often working poor people lose the coverage this way. And I know Audrey and her team have looked at whether it would be feasible to move money around to try to help. And I guess it's not. So the team has looked at this to try to see if there's something they could do from the connector's perspective, and it's outside the realm of possibility, but just want to recognize that you did look at this and we have had conversations about it. Thank you.
You, Rebecca.
Thank you. And Audrey, thanks for that report. And of course, thanks to the whole connector staff that's clearly been looking at this and trying to figure out, what we can do during these really unprecedented, just terrible times of attacks. As the labor representative on the board, I work at 1199 SEIU, and we represent healthcare workers. Some of the people I work with most directly are personal care attendants. These are people who care for people with disabilities and elders in their home. It's a Mass Health funded program. And these workers don't have access to employer-sponsored insurance. And as you can imagine, many of these workers are immigrants with documentation, and some of them will be impacted by this. In addition, our union represents home care agency workers and nursing home workers. And while this group of workers often are offered health insurance through their jobs, that health insurance is often, frankly, bad, low quality, and unaffordable. And so these are some of the people who I personally am in very direct relationship with, who could be impacted. And these are the people, as I'm sure everybody here knows, and Audrey, as you said in your statement, these are the people who are neighbors. They're also the people who are taking care of our parents. They're the people who are taking care of our siblings. They're the people who are going to be taking care of us. And these are people who are providing health care to other people who are going to lose coverage. And I know everybody here is aware of that. It's a huge blow to so many people and also specifically to healthcare workers. And so I don't want us to just sort of sit with that sort of like, I feel bad. I want us to try to figure something out. And I don't come with a particular solution today, but I come with a drive for us to keep trying to figure it out, and appreciation for the connector staff who I know is trying to figure it out. I hope we can work with the legislature, with our administration, to try to figure something out, whether it's about figuring out wraparound services, revenue from other sources. Again, I'm not coming with a specific recommendation, except for us to not just say, I'm sorry, we just need to stop here. And I also hope that in the meantime, that we can track the impact specifically on the folks who are going to lose coverage the type 1 folks, people who potentially the type 3D, who could potentially lose coverage so that we can see, do they just remain uninsured? Do they find another product? What are the very real impacts on those people's lives? So I appreciate being here. I appreciate the work of this board. I know I'm a very new member of the board, and look forward to working with all of you on solutions. Thanks.
Thank you, Rebecca. I see Nancy's hand.
Yeah, thank you, Secretary. First, Rebecca, thank you for those comments and for putting a very human face on these members. As Audrey said, this is the first of many cuts that, if not reversed, are going to affect people here. And in some ways, this is the most troubling one because it affects people with the lowest income who are particularly vulnerable and contributing in all the ways that Becca talked about. I reflect back on 20 years ago when we started first talking about the law that became Chapter 58. And one of the framing principles was shared responsibility. And it was shared responsibility on behalf of everyone in the Commonwealth to work on expanding coverage and help finance it. So I hope we will all feel the same responsibility to work together to find creative solutions to restoring coverage for these type 1 people as soon as we can. And I think that includes finding new sources of revenue. I'm not at all naive enough to think that the state can easily fill a $3.5 billion gap, but I think if we work together creatively, we can find ways to at least bring some coverage to these people and other folks who are going to lose coverage in the months ahead. So.
Thank you for the comments and the thoughts. Next item on our agenda is a presentation on federal policy changes, and I believe it'll be Marissa Wolfman who will be leading the presentation.
Thank you, Secretary. Good morning, everyone. Next slide, please. Okay, today I'll share an update on federal policy activities and what they mean for the Health Connector. Since we last met in June, the Centers for Medicare and Medicaid Services finalized their Marketplace Program Integrity Rule, and Congress passed their Budget Reconciliation Bill, commonly known as the One Big Beautiful Bill Act, or OBBBA. I'll also touch on some upcoming potential areas of activity as we look ahead. Next slide. Thanks. In their Marketplace Integrity Rule, CMS proposed a wide variety of changes to marketplace operations. The Health Connector submitted comments on the rule along with tens of thousands of other commenters. We were pleased to see that the final rule included changes responsive to our comments, modifying some of the provisions that would have had the greatest negative impact on the Health Connector members and the market, or making them not applicable to state-based marketplaces. Of note, CMS had proposed that the upcoming open enrollment period would end on December 15th in all states. While the final rule still imposes limits on state-based marketplaces, states may run open enrollment through December 31st, and limitations on open enrollment length begin for 2027 enrollments, not 2026. We will maintain our January 23rd end date for the upcoming open enrollment period. Since the rule was finalized, a lawsuit led by the city of Columbus, Ohio, resulted in a preliminary injunction that stayed several provisions of the rule, including changes that would have resulted in a higher number of our members losing subsidy at renewal. The court decision came prior to implementation of these provisions, and the Health Connector began redeterminations for 2026 under rules consistent with the order. Next slide. On the legislative side, Congress passed a budget reconciliation bill that the president signed into law on July 4th. The OBBBA's most impactful marketplace provisions fall into two broad categories: elimination of premium tax credits for many lawfully present non-citizens and increased administrative burdens related to the eligibility and enrollment process. These changes begin on January 1st, when 36,000 Health Connector members with incomes below the poverty level will no longer qualify for help paying for coverage. Tens of thousands of additional non-citizens will no longer qualify at higher income levels beginning in 2027. And changes to eligibility verification rules at application and at renewal will impact every Health Connector member beginning in 2028. These federal changes will reverberate through the Connector Care program as well, as it was constructed to wrap around federal subsidies with state supports. Without premium tax credits, 55,000 members will lose access to the Connector Care program and face incredibly challenging decisions about how to manage their coverage and their health care. This level of subsidy loss is unprecedented in our market and will create significant challenges for many who depend on Connector Care coverage today. We'll talk more about how we're working through these changes in our subsequent presentations, but I will pause here for questions or comments. This is certainly a challenging moment for our programs and the population we serve, and it is a lot to process.
Please go ahead, Bella. And then Dana.
Great. I guess I had a question. I don't know if you can summarize it. What are the big eligibility requirement changes? Is there like one big thing?
So the administrative changes look to verify eligibility prior to enrollment. So right now the rules say if there's a discrepancy between federal data service hub results and what an applicant has told us, we'll let them enroll based on their attestation while they send in their proof. Under those new rules, we would have to receive the proof and process it first before they could enroll with that subsidy. And there would be greater scrutiny at times of renewal and more active engagement required. That section of the law is one that we would expect some rulemaking on from CMS to understand how they're interpreting those requirements. So it's a little bit hard to speak to exactly how it would play out, but the gist is pre-enrollment verification of eligibility and kind of more stringent eligibility checks once someone is enrolled.
And Marissa, can you just, so that's one section of ways we'll have coverage losses. And then can you just speak to what the eligibility changes are, like the changes in who will be eligible for APTC?
Yes. So in addition to the 2026 changes where all non-citizens who are under the poverty line who qualify for tax credits because they have an immigration status that doesn't qualify them for Medicaid will lose coverage. The changes that are coming for 2027 limit the types of lawfully present non-citizens who could qualify for tax credits to a narrow subset: legal permanent residents, Cuban Haitian entrants, and compact of free association migrants. These are individuals from a variety of Polynesian islands. We don't have a huge population here. It's more impactful on the West Coast, is my understanding, but it would be those three groups would be the only types of non-citizens who could qualify for coverage or subsidies.
Go ahead, Dana.
I just wanted to thank you and the whole Health Connector team for all your work on this. I know it's been really complicated to try to understand what the changes mean and what the implementation means for the connector and for the Commonwealth. And we really appreciate your partnership. I know we've met several times with you just to try to understand the impact, not only to you all, but sort of across the healthcare system in the Commonwealth, and really appreciate your partnership and all the work that's gone into this.
Thank you so much, Dana. Okay. So next, can move to some upcoming topics. As we move into the fall, we're closely watching congressional dialogue and activity related to enhanced premium tax credits set to expire at the end of the year. Federal tax credit subsidies would be reduced by over $425 million in 2026 relative to what they would have been with the enhancements in place. There's been some media reporting suggesting that this is a topic of negotiation as Congress works on federal funding bills this month, or potentially to be included in other vehicles as late as December. However, the pathway to extension is unclear and uncertain at this time. Staff are working on contingency plans to ensure that the Health Connector is ready to respond to a variety of extension scenarios to make sure that members have access to any subsidies that become available to them. Next. As Audrey mentioned, we've been working with other marketplaces from across the country to raise awareness about the impact of federal policy changes on our members, with a focus at the moment on the expiration of enhanced premium tax credits. Through the State Marketplace Network, convened by the National Association for State Health Policy, National Academy for State Health Policy, marketplaces have put together educational materials and hosted press conferences that have generated national media attention. On the executive front, we will watch for the annual notice of benefit and payment parameters rule that CMS issues each fall, outlining policy guidance for marketplaces. We also expect at some point rulemaking to clarify implementation of provisions in the OBBBA, along with regulations on short-term limited duration plans that was signaled in recent sub-regulatory guidance. The rest of today's presentations will share additional details about how the Health Connector is responding to the near-term changes, including how we'll support members in navigating open enrollment as eligibility rules are changing. A key component of effectively responding to the fast-paced federal environment is continuous and open engagement with our external partners. To that end, the Health Connector is working with MassHealth and DHS to convene Massachusetts healthcare stakeholders to discuss and collectively navigate federal policy changes. We'll continue to provide updates on new developments and their impact on our work at future meetings, and appreciate your support as we move forward.
Thank you, Marissa. I know people had questions during the presentation, but any further questions for Marissa on the federal policy changes? Thank you, Marissa. Next item on the agenda is a presentation on emergency connector care regulations, which will require a vote, and it will be introduced by Andrew, Egan, and Marissa again.
Yes. I will kick us off. This next presentation builds off the federal policy update that I just provided. Can you advance? There we go. And addresses a very technical change that we're looking to make to our program regulations. As I noted, tax credits will no longer be available to low-income non-citizens who currently have coverage in our Connector Care Plan Type 1. However, the way that we've historically defined each of our Connector Care Plan types leaves a gap under the revised federal statute for people with income at exactly 100% of the federal poverty level, which we'll propose a modification to address. Next. One more. Under the current regulations, Plan Type 1 is available to individuals with income up to and including 100% of the federal poverty level, and Plan Type 2A coverage begins at 100.01%. The revised federal statute preserves access to tax credits for individuals with income at 100% FPL. Rather than administer Plan Type 1 for this very small contingent of members, we propose to adjust the lower income bound for Plan Type 2A from 100.01 to 100. Of note, we're not proposing to delete Plan Type 1 from the regulations altogether, but rather propose to adjust its upper income limit to 99.99% FPL. Hypothetically, should tax credit eligibility be restored at some point in the future to these members, the infrastructure to provide Connector Care Plan Type 1 will remain intact. In practical terms, members who shift from Plan Type 1 this year to Plan Type 2A next year will still have access to plans with a $0 monthly premium, but they will see increased cost sharing for some services. And I'm happy to pause here for any questions before turning to Andrew to talk about the regulatory process.
Please go ahead.
That was a great catch, so thank you.
I have a question. Do you know how many people might transition to Plan Type 2 from Plan Type 1?
As a result of this change in particular, we've identified about 10 households where income is exactly at 100 or would be at 100% next year. So it's a very small population associated with this, but there is a lot of shifting going on right now as people are taking a look at their income for next year. They're receiving those notices. So we may see that number change, but that's based on the data that we have today.
Good morning, members of the board. I'll walk us through the emergency regulation amendment process. So just to start, I know we all appreciate open enrollment, and the renewal process for next year's coverage is something that is governed by federal rules. And those rules require that we begin those activities really no later than right now in mid-September. And so given that the normal process to amend regulations can take 3 to 4 months, we are going to instead use the Massachusetts Administrative Procedure Act emergency regulation process. And that's a little different. It allows the regulations to become effective upon filing with the Secretary of the Commonwealth. And those regulations can remain in effect for 3 months, which allows time for a public hearing to take place. So that's the process we'll be using for this change. And then we'll plan to come back to the board, shooting for November, to have a final board vote to finalize the regulations. This slide just describes the very specific technical changes that we're making. And the text of the regulations wasn't included in the board materials shared last week.
So let me see, I can't remember if we go to questions first or to vote first. So I think first questions or comments. Okay, so the Health Connector staff is recommending that the Board of Directors approve the emergency amendment of the regulation at 956 CMR 12 as described in the presentation. Do I have a motion?
So moved. Seconded.
Thank you. And Kathy, if you could lead us into a roll call vote.
Glad to. Commissioner Caljo,
Aye.
Michael,
Yes.
Bella,
Yes.
Eric,
Yes.
Dana,
Yes.
Rebecca,
Yes.
Robin,
Yes.
Dimitri, Secretary,
Yes.
Matt,
Yes.
Nancy.
Yes.
Thank you, everyone.
Thank you. The motion carries. The next item on the agenda is a presentation on the final award of the 2026 Seal of Approval, which will include a vote and be presented by Michelle Yakovy and Marissa Wolfman. Michelle?
Hi, good morning, everybody. Today, we would like to share the Health Connector's recommendations to award qualified health and dental plans the final seal of approval. A vote today will authorize the Health Connector to offer an array of subsidized and unsubsidized plans to our members effective January 1st, 2026. Over the past several months, we've been reviewing carrier submissions to ensure that carriers meet the requirements and standards set forth by the Health Connector as conditions to offer plans to our members. Let me go to the next slide. If you recall, in February, we presented our approach to 2026. Our priority was to maintain a stable product shelf, recognizing that we expected a year of uncertainty around changes to both federal subsidies and the Connector Care pilot. Our proposed plan designs were largely consistent from 25 to 2026, with the exception of a new dental plan. In July, we provided an update on carrier responses to the request for response and included an update on pharmacy changes, NCQA accreditation status, and rate submissions. Today, we will review the final rate changes, review the resulting changes in the Connector Care program design, and provide updates on NCQA Health Equity accreditation and the results of the network adequacy evaluation. Our product shelf remains robust. There were no changes to the list of carriers offering products or their service areas between 2025 and 2026. We offer 48 individual plan options across the metallic plans and catastrophic plans. Additionally, there are 56 options for small businesses and 12 individual and small group dental plans. Medical options include both subsidized plans for easy comparison between carriers, and carriers have the opportunity to supplement with additional offerings. This slide highlights the new dental plan that was added for 2026 for both individuals and small businesses. Both Delta Dental and Altus will be offering this new option, which includes a higher maximum benefit of $1,750. We have also made updates to our shopping portal to highlight the different maximum benefits across the plans and assist members in comparing plan options and their costs. As you're aware, rate increases for 2026 are high across the country. The Massachusetts Division of Insurance conducted a detailed review of the rates filed by the 8 medical insurance companies in the merged market. The average increased rates in the merged market is 11.5%, which is among the lowest increases nationwide. Federal uncertainty, increases in pharmacy trends, and upward pressure from hospital renewals are putting pressure on rates. In an effort to reduce premium increases, all of the carriers made the difficult decision to discontinue offering GLP-1 drugs for weight loss in 2026. As you can see, the average rate increase for unsubsidized plans is 13.7%. The average rate increase for silver tier plans, which underlie Connector Care, is 12.4%, and the average rate increase for dental plans is 5.6%. For members who don't receive subsidies and small employers, they are most impacted by the rate increases. This chart shows the rate increases with and without member aging across the metal tiers. The bronze tier has the highest rate of increase. The catastrophic plans remain a less expensive alternative, and the federal government has recently announced it will be allowing hardship waivers for those over 30 years of age to purchase catastrophic plans if they lose eligibility for advanced premium tax credits. I will now turn the presentation back to Marissa Waltman to speak about changes to the Connector Care program.
Thanks, Michelle. So again, the changes to Connector Care resulting from federal tax credit eligibility changes play out through the seal of approval process as well. We will not be administering plan types 1 or 3D next year as it stands now. If enhanced premium tax credits are approved for individuals above 400% of the federal poverty line at some point in the future, we're prepared to open plan type 3D again under the terms of the pilot. We've included here the minimum enrollee contributions members will be offered for the remaining plan types, and included on the right information about plan type 3D should it become active. Overall, members retain a number of options in each region, and enrollee contribution increases are marginal. In addition to providing a steady state on plan offerings and minimum contributions, we propose stability in our approach to premium smoothing. This refers to subsidies that are provided to plans other than the lowest cost plan in a given region to help, quote unquote, smooth the difference between the cost of plans and offer members a range of affordable options. Under this proposal, plans within $60 of the lowest cost plan have a portion of the premium difference narrowed, and plans between $60 and $260 would have a lower percentage of the difference narrowed. Plans that are more than $260 more expensive than the lowest cost plan and plans in the pilot expansion program do not receive smoothing subsidies. And I'm happy to pause here for any questions before moving to some slides on our health equity topics.
Michelle, just a quick question with regard to the improved to the dental plans and looking historically at the services cover under the QDPs, where it was mostly dental caries that were covered with very limited services. With the increase to the upper limit of roughly $1,700, are there any considerable changes in terms of services that would be covered under those plans? aside from basic dental caries and extractions.
Yeah, our for the dental plans themselves, not the pediatric that's embedded, but the dental plans, they cover a range of preventive, restorative, and major procedures. But there were no changes there was no changes in the coverage from the older plans, from the existing plans to the new plan with the higher maximum.
Thank you.
This is Robin. Sorry, I'm wondering, Dimitri, I know that Mass Health doesn't cover certain services in their plans, and maybe that's what you're thinking. As an ex-dental hygienist, I know these things, but I think for that I know of, these plans cover, like you said, Michelle, the majority of services.
Thanks, Robin.
Please go ahead, Eric.
Thank you. Just regarding the smoothing slide, while we're looking at a steady state, is it fair to say that over time, what we've been trying to do is lessen the smoothing where we can to make the rates more closely reflective of the actual costs that are coming in from the carriers?
Yes, that has been our approach over the last few years. And we have been gradually bringing that upper end cap down. And we're proposing steady state here just to provide some stability to members and carriers in what's been a pretty unpredictable and uncertain rate setting environment.
That's understandable, but our overarching goal is to have the costs reflect more closely the actual cost to the connector. That
Right.
makes sense. Okay, thank you.
No more questions here. Could advance to the next section. Okay, so all health carriers use the National Committee for Quality Assurance, or NCQA, as an accrediting entity to meet federal accreditation requirements. For 2026, we required that carriers add on to that baseline accreditation with the NCQA's Health Equity Accreditation to ensure that carriers are meeting all members' needs. Most carriers have already received this accreditation, but 3 are in process. Mass General Brigham, WellSense, and United are all making meaningful progress toward accreditation consistent with our requirement. Also, we added equity priorities to our quality improvement strategy requirements last year and received baseline data on measures related to maternal health and cardiometabolic health. Overall, this data showed Health Connector carriers generally outperforming national averages, though some measures showed variability. We'll collect this data again this fall as part of the 2026 seal of approval and assess changes across carriers. And if no questions on this, I can hand back to Michelle to talk about.
Marissa, could I ask one question? And I'm sorry, Secretary, I didn't get my hand up fast enough, but is it okay to ask a question?
No, please.
When we look at some of these slides, and this one with the kidney health, we see actually very significant variations across the carriers. 50% differences on this one, it looks like. Are we doing any follow-up with the carriers to see why some of them are performing much better than others?
Yes, we've been digging into this data. We're really interested to see more how this year's reporting goes, what progress has been made as carriers have been taking a close look at this in the context of quality improvement. And we are planning on having those conversations about how they'll continue to improve, especially for the ones that you see that are on the lower end of the spectrum on some of these variable measures.
I know sometimes in the past there have been collaborative efforts across the plans to share best practices and things. And it's always seemed to me quality should be a no-compete zone where it's a collaboration zone instead of a competitive one. So I think anything we can do to instill that kind of sharing of best practices and the plans learning from each other would be great.
Absolutely. Thank you.
Bella, you're up.
Yeah, are the definitions on how to measure kidney health evaluation, postpartum care, are they standard?
Yes, these
Okay.
are existing metrics that we've asked them to take a look at.
Okay. Is it possible that there might be some data quality issues on some carriers versus others in terms of measurement?
Potentially, but I would need to take that back and take a closer look. We can follow up with more detail there.
You know, Belle, at least at the ones I looked at, and we see this even in the slide, carriers ENF kind of were consistently the lowest. So, I mean, not to say that there are not probably always data issues, but there look to be some patterns in the data.
Michael?
So I'm thrilled you're looking at this, and Marissa, thank you very much for looking into it. I do think that's the key theme here. I think it's important to remember that these differences that we're seeing could reflect things that are unrelated to the carriers. It could reflect how the case mix is working. It could reflect the providers that are being seen. In general, my view is plans are important for quality, but providers are really important for quality. And so I think it's really good both to highlight these things to get a sense of where there may be a concern, and wise to dig into what's going on before we react to things that may actually be attributable to factors that aren't being measured. So again, thank you for this.
Yeah.
We probably could agree, if we think a measure is important, that anyone who's below 100% is not doing where we would ideally like to see them, however.
Sure, if they were truly before 100%, and there's a lot of, in other contexts that I spend time, there's a lot of coding documentation stuff that goes on, right? So it really does require some level of investigation, which I think is what Marissa was talking about, and I think that's the right thing to do. I mean, no one's going to argue that everyone should get the best care that they can get, but we've had a long history of quality measurement programs of things we think are important. When they move, we don't seem to see as big a change in health as one might think. So I think some acknowledgement of that is important as we pursue what's going on.
Please, Dimitri.
Thank you. I just wanted to dovetail Michael's point in terms of we have to look a little bit deeper at this data. If we're simply looking at the plan, we're not looking at the provider mix and the member mix in terms of who's providing service to whom. And clearly, we're going to see data that's going to be a little bit lower as it relates to quality for providers that are providing services to a sicker pool of patients. So making sure that we're able to really look at the data and triage through what we're looking at to ensure that we're getting what we need from that data, I think is very critical.
Thanks for that, Dimitri. And again, this was year one of collecting this data. It's certainly not the last year. And while carriers are comparing favorably to these national averages, that's certainly not a, reason to stop focusing on this. And this is really designed to be a multi-year effort in conjunction with the carriers to focus on and improve quality in these particular domains. So we'll look forward to working with them and to reporting back to you on progress as we go forward.
Right, I will take it back. So we're going to now talk about network adequacy. For plan years beginning on or after January 1st, 2026, new rules require that state exchanges impose quantitative time and distance network adequacy standards for QHPs and QDPs that are at least as stringent as standards for those that participate on the federal exchange. In order to provide market consistency, the Department of Insurance made the decision to adopt these same federal standards in determining network adequacy for all merged market networks in Massachusetts for 2026. Together, we contracted with Quest Analytics to assess network adequacy using the CMS alternative time and distance standards. The new time and distance standards take into account geolocation, which gives more accurate time and distance along routes that sometimes include crossing water, traversing bridges, and going around mountains. After a detailed evaluation of each place where carriers didn't 100% meet those time and distance standards, the DOI has granted a 1-year exception for any outstanding gaps for 2026 plan year and has approved network adequacy for all carriers. The carriers are also providing action plans for addressing any fillable gaps that have been, and those action plans have been provided to the DOI. Next slide. So these are network adequacy results. The results revealed very high levels of network adequacy across all networks offered. The dental carriers have met 100% of the adequacy standards. And as you can see, medical carriers have met almost all standards across counties and specialties. Where gaps can be filled, again, carriers are taking action to fill those gaps and have submitted action plans to the Department of Insurance. However, some of the gaps that we have seen are systemic across carriers and there are no providers available to fill those gaps. Any questions before I turn it back over to Secretary for roll call?
Looks like that was a popular topic. Many hands popping up. So Eric, please go ahead.
I defer to the commissioner first, both because I respect him and want to hear what he has to say, and he might answer my question.
Thanks, Eric. I hope I earn your respect. I really just wanted to thank the connector and our team at the DOI for the strong collaborative approach on this topic, which included months of work. Overall, we're in a very strong network adequacy position, especially compared to national data on the topic. During the review conducted by the DOI and the connector, each network was reviewed in relation to county-specific standards. We used time and distance standards to evaluate the providers in a network available for that geographic area. And when there were gaps, we either identified that there were no providers of a specific type available in that region, or we identified those providers who might be available. Carriers then were tasked to work to contract with those providers when they were available. And in this first year, there were some carriers that requested what amounts to a fairly minimal amount of exceptions. There's about 5% of the total studied areas where there was a request for exemptions. If there were providers available to fill that gap and the carrier is working to complete contracting and credentialing, we essentially gave them more time to complete that work beyond the time of this board meeting. And they have filed detailed work plans with us, and they will continue to proceed with that contracting work. So I think it's going to improve. There are definitely still areas where there are no providers available for a particular specialty or a particular service in a region. And I think that means that there will always be less than 100% network adequacy in any state, and in Massachusetts. That brings up larger capacity issues for Massachusetts that I know we have addressed and will continue to address in different areas. But I just want to mention that the carriers are dedicated to the task. They've been productive and integrated with us in this work and have been respectful of our process improvements in the area. I also think that this draws out the need for network adequacy to flow into directory adequacy. And we're working with the insurance companies to make sure that the information contained in their provider directories are adequate. And when a consumer looks at information or researches information about their particular product in their provider directory, it's accurate. And it's not a ghost network or an illusory network of capacity that's put out there. That continues to be something that needs to be improved, and our carriers are tasked to improve it, and we see improvements already happening. But I also want to note network adequacy is two things. It's not just the actual improvements, it's the ability of the member to actually look at the data and find their doctor. And it takes two to tango. The provider also has to provide accurate information to the carrier about their office hours, their specialty information. And so a lot of the work that's happening now is that interaction between providers submitting the data and the carriers putting into their directories. That's all I wanted to say.
Thank you, Michael. And Eric, what happened to your faith in your question?
I have full faith and confidence. I wanted to thank the commissioner for all he's doing to address this, and I think he knows as well as I do that sometimes perfect can get in the way of good, and sometimes 100 doesn't have to be the absolute goal. It's always a balance, right? And I was always surprised to see this network adequacy result because I work in the industry and we haven't seen like people yelling and screaming about not being able to find it. There are some exceptions on the behavioral health side. There's always a need for more, but I just didn't want us to lose sight that it's a balance, and we want our rates for everyone to be affordable, and I wouldn't want to in the goal of getting to perfect 100%. I wouldn't want to put our industry in a position where they have to write blank checks to the only provider in a particular zip code in order to meet some goal that may not be entirely reasonable. So that's all I wanted to say. Thank you.
Well, thank you, Eric. Any further questions? Okay, so we'll move to the vote. The Health Connector staff recommend that the Board of Directors award the 2026 seal of approval to all QHPs and QDPs proposed by the carriers presented on the slide. Do I have a motion?
So moved.
Second.
Thank you. And Kathy, if you could take us through the roll call.
Okay, of course. Commissioner Caljo,
Aye.
Michael,
This is a humbling presentation, but yes.
okay, Bella,
Yes.
Eric,
Yes.
Dana,
Yes.
Robin,
Yes.
Dimitri. Did I hear him?
Yes.
Thank you. Secretary,
Yes.
Matt,
Yes.
Nancy.
I'm going to vote to abstain from approving the seal of approval. And I'm doing that because the plans are excluding GLP-1 coverage for people with obesity. And I know this isn't a connector policy, that it's a decision that the plans made, which the state is permitting. And I know the policy, at least I think I know that it's consistent with what Mass Health and the GIC have done, and also what Medicare is doing. I'm abstaining because I think the exclusion continues an ugly history in health insurance of allowing adverse social judgments against certain groups to be allowed and enable discrimination and medically unsupported policies that are wrong and will damage health for many people, including the people who could most benefit from these drugs. It reminds me very much of my early years as an insurance regulator, where in the early days of AIDS, insurers tried to deny treatments for people who they believed got AIDS in certain ways, so that innocent people who got AIDS through blood transfusions should have treatment, but gay men should not. It also reminds me of the early days of hepatitis drugs, when those were initially not available to people who were injection drug users, or people who couldn't pass sobriety restrictions, requirements. I think this misunderstands the nature of obesity as a metabolic condition. I think it ignores the clinical benefits of these drugs, particularly for people who are obese, weight loss, lower risk of adverse cardiovascular events, decreases in the onset of diabetes in people who are pre-diabetic, reductions in obesity-related cancers. Those are just a few of the clinical benefits. And I know the carriers are saying that they're doing this for reasons of cost. But I just can't support something that is, in my view, holding people with obesity hostage to the inability and unwillingness to take other actions that I think would address cost factors that are much more important in terms of what's causing rising premiums, important in terms of what would actually get them under control. So I abstain.
Okay, and
Thank you, Nancy.
okay, and I skipped over Rebecca. I'm sorry, I missed you.
Thank you. Actually, with that history in mind and that analysis, I will abstain.
Thank you, everyone.
Thank you. The motion carries. And the last item on the agenda is a presentation on open enrollment for the 2026 readiness, presented by Patricia Grant, Signe Flieger, and Jason Leffers.
Good morning. I will be leading off by review of 2026 open enrollment readiness. The Health Connector is preparing to support renewing members and new applicants during open enrollment for 2026 plans. Consistent with prior years, the 2026 open enrollment period will begin November 1st and go through January 23rd. During open enrollment, Massachusetts residents can enroll in or change their health or dental plan for any reason. Today, we will walk through the Health Connector's open enrollment preparations that are underway across the agency. As noted earlier by Marissa, federal policy changes will significantly impact 2026 eligibility for advanced premium tax credits and the Connector Care program. One of the Health Connector's goals throughout the 2026 open enrollment period is to ensure that members are aware of these federal policy changes and how they may impact their coverage for 2026. Current members are already hearing about their expected 2026 program eligibility. Preliminary eligibility notices, these are notices that go out well before open enrollment starts to let members know about their expected program eligibility for the next year, started to be distributed to members in late August. For several individuals who are expected to fall into income eligibility for Connector Care Plan Type 1, which includes individuals below 100% of the federal poverty level, Connector Care Plan Type 3D with income between 400 and 500% of the federal poverty level, and APTC only for individuals with incomes above 500% of the federal poverty level, they will receive an expected program eligibility for 2026 of a Health Connector plan without financial help, also known as unsubsidized coverage. Staff are working collaboratively across the agency to ensure members and community partners are aware of these federal policy changes and how they are impacting eligibility, both through the creation of a federal updates page on the Health Connector website that explains these changes in plain language, and through action-oriented mailers targeted to the members most impacted by these eligibility changes. Staff have been working throughout the summer to implement a series of federal policy changes, some of which went into effect on August 25th, and some of which will go into effect on January 1, but therefore need to be in place in advance of the start of our open enrollment preparations for 2026. These implementation activities included a quick pivot on a couple provisions from a CMS final rule that were stayed as part of a recent court decision. As a result of that court decision, the Health Connector reversed planned implementation of two provisions in the CMS final rule. Not implementing these provisions will result in more people retaining eligibility for subsidies in their expected 2026 program eligibility. Because there are so many federal policy impacts this year, we are working to improve our open enrollment data monitoring to enable us to better track member movement in response to these federal policy changes. These data will enable us to monitor the scope of federal policy changes and support members to update their accounts and provide needed documentation to ensure that their 2026 program eligibility accurately reflects the individual circumstances. We are also developing data tools to provide assisters with actionable data to support members throughout open enrollment to ensure they can take the necessary actions to enroll in the best coverage available to them. Lastly, we are developing plans to prepare for the potential extension of enhanced premium tax credits for plan year 2026. If this happens later this fall, perhaps even after the start of open enrollment, it will require quick implementation timeframes to ensure members can obtain access to the best coverage possible. If this occurs, it could be an as-is extension of enhanced premium tax credits in their current form, or a modified approach that may require additional systems changes. Notably, if there is federal policy action that extends eligibility for premium tax credits beyond 400% of the federal poverty level, that will enable the Health Connector to extend eligibility for the Connector Care program accordingly up to 500% of the federal poverty level. We have some draft timelines for how we would implement these changes depending on when federal policymaking occurs, taking into account feasibility of systems changes and the timing of member notifications to ensure they can get into the best coverage option available to them, including maximizing both federal and state subsidies if available. Our goal would be to have those changes in place in time for a January 1 coverage start date if possible, again, depending on the timeline for federal action. There is a lot of uncertainty heading into this open enrollment. However, the Health Connector has experience moving rapidly in response to policy changes. We were able to implement these enhanced premium tax credits quickly when they were first launched in 2021, and we aim to be as nimble as possible if a similar policy change were to occur here. We also expect that if this happens late in the year, we would be in good company among other state-based marketplaces to strategize how best to get enhanced premium tax credits implemented in a timely way to support greater access to affordable coverage. I will now turn it over to Trish Grant, who will discuss our approach to systems readiness for open enrollment.
Thank you. Planning for open enrollment begins long before it actually commences. The Health Connector IT team begins working with vendors on releases that will include systems updates and changes for the upcoming OE over a year in advance. This slide shows the timeline required for both Optum on the HIX side and our enrollment and premium billing vendor to get our systems ready for OE go live. Development and testing must occur not only within these systems, but also with carriers, our contact center and technology vendors, and involves our internal policy, operations, legal, and communications teams. Next slide. Preliminary eligibility is a process that happens each year, and we work closely with our vendors to make sure our systems are ready. This year, we began preliminary eligibility on August 27th and expect it to be completed by September 15th. What is different for us this year that adds a layer of complexity to our systems is the changing federal guidance. Given we may need to pivot quickly with any federal changes, with the help of our partners at Optum, our HIX system has been proactively configured to be flexible so that any last-minute changes that must be made can be done so quickly. Finally, given the downstream effects that any systems changes may initiate, our internal teams are prepared to regroup to ensure that our members are provided with the most up-to-date information that may impact their eligibility and enrollment. Next slide. On the contact center side, we have increased our staffing to include an additional 148 representatives across both our current vendor, AHS, and our overflow vendor, Accenture, to ensure the highest level of customer service for our members. This year, we are open from 10 a.m. to 6 p.m. on the Saturdays of pay weeks, including January 24th, which is the day after open enrollment ends. Historically, we've experienced high call volumes right after the close of open enrollment, all the way through the end of January. So we are remaining open that Saturday, January 24th, and will retain our increased staffing levels until January 31st. We've also made available to our staff and vendors our detailed open enrollment member communications calendar so that staffing levels in our contact center can literally be planned hour by hour based on when communications are scheduled to be sent to members. This is especially important with respect to our SMS and robocall campaigns, as call volume spikes soon after those types of communications are sent. Finally, we have worked to make sure our contact center agents have been provided with training on the most recent federal policy changes so that they are able to assist callers who have inquiries related to recent changes that fall outside of the more routine questions we expect each year during open enrollment. Before I turn the slides over to Jason, I do want to make note that this will be our first open enrollment with our new contact center vendor, AHS, as our contract with Accenture ended this past August. While Accenture is providing support to us as a small overflow call center through January 2026, they are no longer our primary vendor. On behalf of Audrey, Kimberly Mercure, our Deputy COO, who has worked closely with Accenture, and myself, I would like to formally acknowledge Accenture and take a few moments to read a quick note of thanks from the Health Connector to the Accenture team. The past 6 years have been the most rewarding and the hardest work for many of our professional lives. We began with an emergency procurement to stand up a call center and staff the customer interaction centers. As a team, the Health Connector and Accenture embraced the chance to work together to provide access and support to individuals and families across Massachusetts who are our members. For us, it was a pivotal point in our history as we overcame daily challenges and executed a contract and a partnership to regain our place in the healthcare landscape of Massachusetts. We faced many challenges coupled with the complex nature of our business. Finding the right solution was daunting and did not always come quickly or easily. However, we were fortunate from the start to have a deeply committed and dedicated Accenture team who never gave up or gave in. And so together we began this long, sometimes elusive journey, including working through the uncharted territory of the COVID-19 pandemic, arriving at a destination today in which we should all take pride. As we reflect on these past 6 years, we are proudest of those achievements that required collective effort, tenacity, and mutual trust, even when we couldn't see to the end of the road with any assurance of success. Today, we can proudly report that together we have assisted our members with over 90,000 in-person interactions and have handled over 5 million phone calls. Although some of the names and faces have changed over the years, Accenture's commitment to our membership has not, and for that we are grateful. To our dedicated team at Accenture, we thank you for your partnership, your collaboration, and your unwavering support as you transitioned out and gave 100% to assist our new vendor transitioning in. This recent transition would not have been as successful as it was without the Accenture team. As we close this chapter, please know that your hard work, commitment, and passion have been deeply appreciated. You've made a lasting impact on our members and our community, and for that, we thank you. I will now turn it over to Jason to wrap up the open enrollment readiness review.
Thanks, Trish. Good morning, everyone. I'm just going to spend a couple minutes here talking about updates around communications and outreach as we head into open enrollment. First and probably foremost is around member communications. As we've discussed throughout the morning, current members are going to see a number of changes this open enrollment due to federal policy changes and premium increases. We plan on reaching out to impacted members early and often throughout open enrollment. We've actually already started raising that awareness with our first broad awareness messages being delivered starting August 15th to all subsidized members. At the same time, we launched a new website, mahealthconnector.org/updates. This website provides information on specific changes along with guidance on actions members can take at a particular moment in time. We will continue to update that website as we get closer and into open enrollment and members have the ability to take further action. Up front, we want members to be aware of these changes and the impacts that it will have on their eligibility or premium costs for next year. We're always encouraging members in these messages to update their account information to ensure any eligibility changes are captured. And as we get into open enrollment, we'll provide additional details on specific options and actions members can take depending on their situation, along with the availability of help through the contact center, navigators, and other assisters. This very well may be a confusing time for folks, and we want them to know that help is available. We're timing specific communications with important steps along the way. preliminary eligibility, which is just wrapping up final eligibility in late October and into November. And then in early December, when the January invoices are mailed, is always a time we know people really pay attention to changes in their plan for the next year, and when they are most likely to have the urgency to act. Plan type 1 and tax credit loss members are going to receive communications that include this account update message, along with specific steps on what to do to find new coverage starting in late September and then throughout open enrollment when they can take action. And then members experiencing premium changes will receive general messaging before open enrollment, and then in November begin to receive specific detail. And there's going to be kind of two different sets of messaging there, depending on if someone's in connector care or if they're in unsubsidized coverage, because the options available to folks is different depending on their status there. If we go to the next slide, Nuri. On marketing strategy, enrolling uninsured residents remains a priority for us during open enrollment, and we want to continue to reach out to those who need coverage. We are planning on adjusting our marketing strategy a little bit this year. We've used broad-based platforms quite a bit in recent years as we supported residents through the Medicaid redetermination process. This year, we're going to narrow our focus a little bit more tightly on communities with higher uninsured populations. Our policy team did a great job this spring being able to dig into data, and they were able to identify 27 communities for us to prioritize. Commissioner Caljo, sorry.
I can wait until you're done, Jason. I just want to make a comment at the end.
Okay. So we're identifying 27 priority outreach communities. Generally, these are larger cities, gateway communities, and regions like Cape Cod that either have a higher percentage of unenrolled people or just a larger number of unenrolled people. This is an expansion from our previous list of about 20 communities. In all, this is more than 100,000 uninsured residents in these 27 communities. It's probably close to half of the state's uninsured population based on published uninsured rates. So we're going to prioritize our media buy in these communities to more directly increase awareness and visibility there. We're going to use digital platforms, including online and geo-targeting options that can focus our resources in these specific areas. And we'll use out-of-home options like billboards, public transportation, and other uses that will make sure our messaging is directly reaching these intended audiences. Historically, we've had a really good presence in local non-English media outlets. They've been great partners to us for a number of years, and they have the ability to reach into their local communities and deliver information to their audiences. And we're going to continue to work with these folks for this open enrollment. And then historically, we've scheduled in community activities in our priority outreach communities, things like a mall tour. We did some flyering late last open enrollment in takeout restaurant orders that was really good. So we're going to continue to prioritize participation in those visibility events in those areas. I can pause and I see the Commissioner and Rebecca both have questions.
I really just want to make a comment praising the Connector's proactive marketing strategy. It's top of class. I have the opportunity to see nationally other exchanges and the activities that they are putting into place to reach their communities at a time of intense change. And this program is right at the top level of any across the country and will be needed more than ever this year. I kind of have an observation and kind of leads to a question, which is, some of this is still changing, and some of the information that you're presenting is capable of still morphing. And I was wondering if you could comment about the flexibility and how you would seek to address that in the plans moving forward if an item changes because of federal action or inaction on a particular issue, like the tax credit policy. And then secondly, if you have any thoughts, you or the team, Audrey, around how the Connector's approach compares to prior years in terms of the placement of the outreach, given the environment that we're operating in, in Massachusetts and nationally in terms of potential patients signing up or being sort of interested in signing up, but not really sure how to do so and whether or not this is largely consistent with prior years or if you've tweaked it in any way, given the current landscape and environment that we see out there in our communities.
Yeah, so on your first, we will have the ability to adjust our messaging quickly as necessary, whether it's a direct communication to members, we can obviously adjust those. We have ways to, through email, robocalls, texting, we can get to people immediately if something were to change. I think in terms of how we're reaching out to people, I think that change again is, I think we're going to be doing a little bit less of that sort of the broad-based, very broad platforms that we've done in the past, not so much of that, and more of that really targeted in these communities where we know that there are uninsured people and just reach out to them directly, even more than we have in the past, and encourage them to take action.
Please go ahead, Becca.
Thank you, and thanks for this plan. It looks like a really strong plan. 1199, again, the union I work with has been really proud to partner with the connector in the past in terms of getting out to our members who often rely on connector products. And so we look forward to continuing to do that. My question is there a possibility to partner with other unions potentially? And then also, and I don't know if the connector has done this in the past, but partnering in with public schools in particular communities that would be impacted. I don't know if that's possible, but I was just curious if that's something that.
Yeah, oftentimes when we work with schools, it's often through our navigator organizations. They have connections with their local school systems. New Bedford comes to mind. I think for a long time, the New Bedford schools have been pretty active in encouraging people to sign up for health insurance when they bring a new student in for the school year. And yes, I think we are always open to working with other unions and folks who have an interest in getting their membership enrolled. And I know that it's the PCA work has been great with Melissa Montron. She's been awesome with you guys. I know you guys do a lot of outreach during open enrollment, directly reaching out to PCAs, and we look forward to continuing that this fall for sure.
Oh, please go ahead, Eric.
Oh, thank you. So we've been through this communications challenge before with redetermination, and I thought you did a great job with that. As you know, I sit in the NABIP seat, which represents all the benefit brokers and by extension all the employers out there. And so if there's anything we can do to help, especially with the changes on the legally present non-citizens and the 400 to 500% poverty, if you can provide any sort of like FAQ or heads up, here's what's going on and how it might impact you as an employee, maybe having people come to you newly eligible and here's why, and I can get that out to the broker community by extension, start to get the employers ready for this as they get some people coming to them. Happy
Great.
to help.
Thank you. We absolutely have that, and I'll make sure we get that to you.
All right, thanks.
ASAP. Yep. Okay. Can we go to the next slide, please, Nuri? Thank you. So then when it comes to press outreach, we are making a few changes there. We're looking to enhance our press outreach this open enrollment. We're engaging with Lavoie Health Sciences. They're going to help us. We're going to create a series of press events throughout open enrollment. We'll be looking for other avenues to place stories and information that encourages people to enroll into coverage. Similar to our marketing strategy, we're going to focus this on our priority outreach communities. The thing here is that this really already includes most of what we would consider to be the largest media outlets across the state, including TV, radio, and regional news outlets, like regional newspapers and websites. Along with creating new ways for us to share this proactive messaging around enrollment for uninsured residents, maybe kind of getting back to Commissioner Caljo's comment, this should also help allow us to develop avenues to quickly push out news if updates are warranted. In particular, if enhanced tax credits are extended at some point, and we need to very quickly update members and potential applicants of additional subsidy, we should be able to lean into this relationship to get word out as quickly as possible. And then just on next steps, open enrollment starts in about 7 weeks. We're going to finalize putting in place the pieces that we need to ensure that members and applicants are able to access new coverage during open enrollment. We're going to support current members through the changes they're experiencing and encourage uninsured residents to get covered, as we traditionally do. And we will provide you regular updates as we get into open enrollment and see activity by both members and new enrollees.
Thank you, Jason. I know the people ask questions in the presentation, but do we have presentations for any questions for any of the three presenters?
Secretary, I have a question. I don't know if it, who's going to be tracking in as real time as possible what the effects of all of these changes are in terms of our coverage rate in the state?
I'm happy to take that. It's a great question, Nancy, and we are committed to making sure we have kind of as real time as possible lines of sight into what's happening. So we'll see that with our own data, which we track, frankly, from a daily perspective throughout open enrollment, so we can see people that are disenrolling or switching plans and the like. We won't have, of course, the meta level kind of market-wide, statewide research that CHIA and others do. That's obviously survey-based and kind of longer lags between, but I think we'll be able to see what's happening inside of connector coverage and kind of graft that onto what we know about the rest of the market. And we're committed to doing so that we really understand what is what's happening really on a month-to-month basis.
You may remember, Audrey, and because you were involved in it, as I recall, some of the reporting we put in place in the early days of Chapter 58, so we could just, track as well as possible kind of changes. So I wonder if this might be a period to work with CHIA and PC and GIC and others to see if there's something we could do that's more real time, even if we know it's not entirely accurate.
I think we can definitely take a look at that and thinking about kind of like a dashboard of, market and enrollment dynamics, which, yes, we definitely did in early Chapter 58, and we've done at other moments. I think even during the public health emergency, Commissioner Caljo, I'm just remembering, I remember working closely with Kevin and folks at DOI, because I know DOI gets regular, essentially administrative data from the carriers on maybe a monthly basis, maybe quarterly.
I think it'll make sense so that we can track in real time what's happening.
Yeah, absolutely. Okay, we'll put our heads together on that and loop back Nancy.
Eric?
Yes, I was just thinking the impact on employers for this Tier 1 group again. And we may need to come up with some specialized messaging, because the Affordable Care Act, for groups that have over 50 full-time equivalent employees, the Affordable Care Act requires that employers don't charge more than roughly 10% of employees' income towards health insurance. And so the employer community would have made that calculation perhaps based on a higher number, because these folks at the lowest income range were getting their coverage to the government and they're waiving. And so we may need to alert them that, hey, you may need to look at your contribution strategy and make sure it still complies with the Affordable Care Act, as these very low wage workers are coming back to you. So I'm just putting that maybe for me and Jason to work on together as we figure out our communications to the employer community.
Great, thank you.
Further questions for the connector team? Audrey, any last words?
No, just thank you to my team. Thank you to this board for your support. Always feel grateful, but especially right now with so many headwinds and complex challenges in front of us. So the discussion, the dialogue today, just incredibly helpful and appreciated.
Thank you all. I'll now entertain a motion to adjourn.
So moved.
Second.
Thank you. And Kathy, can you lead us once more?
Of course I can. Commissioner Caljo,
Aye.
Michael,
Aye.
Bella,
Yes.
Eric,
Yes.
Dana,
Yes.
Rebecca,
Yes.
Robin,
Yes.
Dimitri,
Yes.
Secretary,
Yes.
Matt,
Yes.
Nancy.
Yes, thanks,
Thank-
Kathy.
Thank you, everyone.
Thank you. The motion carries.
Bye, everyone. Thank you.
Thank
Bye.
you. Bye-bye.
Thanks, everyone.